I want to tell you about the most common mistake I see NP students make when they start preparing for boards. And it is not studying the wrong content. It is not using the wrong resources. It is not even studying too little, though that does happen. The most common mistake is preparing for an exam they did not actually sign up for. Here is what I mean. A student decides she is going to take the AANP. She starts searching for board prep content. She finds resources, practice questions, a study plan. Some of it is current. Some of it is from 2022, and the blueprint has changed since then. She studies hard. She goes in ready. And then she sits down at that computer, and the questions feel different from what she practiced. The wording is slightly different. The emphasis feels different. She gets to a question about something she studied, and the answer she expected is not the right answer. Not because she does not know the clinical content, but because she did not understand how the AANP specifically tests that content. Or, and this one is even more common, she prepared for the ANCC using study strategies designed for the AANP. She focused entirely on clinical management. She skipped the professional role content because it felt like soft material, not real clinical knowledge. She gets to the exam and 15 questions are about ethics, scope of practice, evidence-based practice hierarchy, and regulatory obligations. 15 questions she was not prepared for. That is 10% of her scored exam. Both boards test the same clinical content, but they test it differently. They weight it differently. They format it differently. They approach the professional role differently. And preparing for one without understanding the structural differences from the other is one of the most preventable reasons NP students fail boards. Today we are going to fix that. Both boards, side by side, decoded. Athena, the Greek goddess of strategic wisdom, did not win battles by having the most soldiers. She won by understanding the terrain, deploying her resources precisely, and knowing exactly which move to make at which moment. That is board prep done right. Let's get into it. Welcome to Think Like a Provider. I'm Jenna Way, nurse practitioner, clinical educator and creator of Think Like a Provider, the clinical reasoning educational platform that teaches nurses and nursing students to master body systems through pathophysiology and evidence-based frameworks. We don't memorize here. We understand. If you're new, every episode we break down the mechanisms behind clinical reasoning, neuroscience, and what it actually takes to perform at your best, so you walk away thinking and acting like the provider you are meant to be. And if you want to go deeper than a podcast can take you, we have clinical reasoning tools, ebooks, and a growing Facebook community where we break this down together every single day. And if you are ready for the full Academy experience, the Think Like a Provider Academy waitlist is open now. All the links are in the show notes. The greatest clinicians in history reasoned their way to the answer. So will you. Let's get into it. Welcome back to the NP track. This is the dedicated space in Think Like a Provider for NP students and practicing NPs. Mechanism-based content that maps directly to what both boards are actually testing. And today's episode is the one you need before you open a single practice question bank. Because understanding the structure of what you're walking into is the prerequisite for studying it effectively. Strategy first, content second. The fundamental difference in one sentence. Let me give you the core distinction between these two boards right up front, because everything else builds on this. The AANP asks, what would a skilled clinician do? The ANCC asks, what would a skilled clinician do? And how is that decision consistent with current evidence, ethical obligations, and APRN professional scope? Same clinical scenario, same patient, same presentation, but the AANP is testing your clinical judgment and the ANCC is testing your clinical judgment plus your professional identity as an advanced practice registered nurse. Those are related competencies, but they are not the same competency. And preparing for one without understanding the distinction is why students who know the clinical content still fail the ANCC. Let me build on that with the structural comparison, because the differences are not subtle. The AANP-FNP exam, also called the FNP-C after you pass, has 150 questions total, with 135 questions that count toward your score, and 15 pretest questions that do not count, but you cannot identify which is which. You have 3 hours. The format is predominantly single answer, multiple choice. though the 2024 blueprint acknowledges that alternate formats may appear. The credential you earn is FNP-C. The 2025 first-time pass rate was 81%, down from 83% in 2024. The ANCC FNP exam, the FNP-BC, has 175 questions total, with 150 scored and 25 pretest. You have 3.5 hours. The format includes multiple choice, but also multiple response questions where you select all that apply and other alternate item types. The credential you earn is FNP-BC. The 2024 first-time pass rate was 83%. Both exams are at the testing center. Both require NP program completion and clinical hours. Both certify entry-level NP competency, but the way they measure that competency is structurally different, and your study strategy needs to account for those differences. The AANP Decoded. Let's go deep on the AANP first, because the 2024 blueprint change is something every NP student preparing for boards right now needs to understand. And the majority of older study resources do not reflect it. In January 2024, the AANP-CB implemented a new FNP exam blueprint. The most significant change was a redistribution of questions across domains. Here is what changed and why it matters. The assess domain, Domain 01, increased from 36 questions to 43 questions. It is now the single most heavily weighted domain on the exam, representing approximately 32% of your scored questions. If you are spending most of your study time on management and prescribing, you are studying the wrong domain at the expense of the most tested one. The diagnosed domain, Domain 02, increased slightly from 35 to 36 questions. The planned domain, Domain 03, increased from 34 to 36 questions. The evaluate domain, Domain 04, decreased to account for the increases elsewhere. What does this mean practically? It means the AANP in 2024 and beyond is testing your ability to assess, to gather subjective and objective data, perform and interpret physical examinations, order and interpret diagnostics, and screen appropriately, more heavily than it has ever tested it before. This is not a coincidence. It reflects what the evidence shows about where clinical errors occur in NP practice in the assessment phase. Getting the diagnosis wrong because the assessment was incomplete, missing an early deterioration sign, like we talked about in episode 13, because the assessment was not thorough or the data was not interpreted correctly. The assessment domain is the domain that requires the most mechanism-based thinking. You cannot correctly interpret a diagnostic test without understanding what it is measuring and why. You cannot correctly assess a patient without understanding the pathophysiology producing their presentation. The AANP is testing clinical reasoning from the ground up, and the assess domain is where that reasoning begins. Now let's talk about the age distribution, because this is the other major 2024 change that students frequently miss. The AANP is a family nurse practitioner exam, which means it covers patients across the entire lifespan. And the age distribution matters because 22% of the exam covers patients from newborn through adolescent. That is roughly 30 questions out of your 135 scored questions that are pediatric content. If you are an NP student whose clinical hours were heavy in adult primary care and light in pediatrics, which describes the majority of NP graduates, you are walking into an exam where more than 1 in 5 questions requires pediatric-specific knowledge. The 2024 blueprint also introduced a toddler age category and removed prenatal as a standalone category. Pregnancy-related content is now embedded within the adolescent, young adult, and middle adult age groups. This means a question about prenatal care no longer announces itself. It may appear as a question about a 24-year-old woman who happens to be pregnant. Now let's talk about how the AANP tests the content, because the question format has specific patterns that reward mechanism-based thinking and penalize memorization. The AANP is known for precise clinical language. When a STEM says most likely, it means the single diagnosis that best fits the complete clinical picture as presented, not the most common diagnosis in general, the diagnosis that fits this patient with this presentation. The mechanism of the presentation is what makes one answer correct and 3 answers plausible. When a STEM says most appropriate initial, it means the first step in the clinical sequence. Not the most important test overall, the first one, the test that screens or the action that happens before everything else. Get the sequence wrong and the answer is wrong, even if you know the clinical content. When a STEM says next best step, it may not be a diagnostic test at all. It may be a referral, a communication, a follow-up interval, the next logical clinical action, not the next test on a list. The AANP is also testing pediatric content in ways that require you to know not just the diagnosis, but the age-appropriate presentation, the age-appropriate treatment, and the age-appropriate developmental context. A fever management question answered correctly for a 3-year-old is answered differently than for a 3-month-old, and both appear on your exam. Finally, the pass rate. The AANP first-time pass rate dropped to 81% in 2025, down from 83% in 2024. That means roughly 1 in 5 NP students who sit for this exam do not pass on their first attempt. The students who fail are not unintelligent, and they are not unprepared in the general sense. They are studying content without understanding the framework the AANP uses to test it. Mechanism-based thinking, assessment domain depth, and age-appropriate clinical knowledge. That is the framework. The ANCC Decoded. Now let's talk about the ANCC. And I want to start with something important that most board prep resources have not yet caught up with. The ANCC updated their FNP test content outline in September 2025. That means if your study resources were published before that date, the domain weights you are studying from are outdated. Here is what the current ANCC blueprint looks like. The ANCC FNP-Bar C exam now has 5 domains with the following weights: assessment at 19%, diagnosis at 17%, planning at 19%, implementation at 29%, and evaluation at 15%. The implementation domain at 29% is now the single largest domain on the ANCC exam. And here is where many NP students get blindsided. Implementation in the ANCC framework is broader than clinical management. It includes therapeutic interventions, patient education, anticipatory guidance, care coordination, and critically, the professional role content that distinguishes the ANCC from the AANP, legal and regulatory considerations, ethical decision-making, evidence-based practice integration, and scope of practice questions all live within implementation. So when you hear me say the ANCC has a professional role component, it is not a separate standalone section at the end of the exam. It is woven into the largest domain on the exam. It appears in clinical scenarios. A question about prescribing a controlled substance may also be testing your knowledge of state regulatory requirements. A question about a patient refusing treatment may also be testing your understanding of the ethical principle of autonomy and the legal obligations it creates. You cannot separate the clinical content from the professional role content on the ANCC because the exam does not separate them. Let me be specific about what falls under the implementation domain and what you need to know. On the clinical side, implementing treatment plans, prescribing medications, ordering interventions, managing chronic conditions, providing acute care within your scope, and coordinating care with other disciplines. This is the clinical management content that overlaps with the AANP's plan domain. On the professional role side, evidence-based practice, which means you need to know the hierarchy of evidence, systematic reviews above RCTs above cohort studies, how to apply research to clinical decisions, and how to evaluate the strength of a guideline recommendation. Ethics, the 4 principles of autonomy, beneficence, non-maleficence, and justice, applied to clinical scenarios not recited as a list. Legal and regulatory considerations, what your scope of practice allows in various regulatory environments, mandatory reporting obligations, informed consent requirements, collaborative practice agreement implications, and therapeutic communication. The ANCC tests motivational interviewing, anticipatory guidance, shared decision-making, and therapeutic boundaries in the context of real patient scenarios. The ANCC also has 5 domains now compared to what was previously a 4-domain structure, and the evaluation domain, at 15%, tests your ability to assess the effectiveness of your interventions and modify plans accordingly. This is the did what I did actually work and what do I do if it did not domain. follow-up intervals, monitoring parameters, reassessment after treatment initiation, all of that lives here. Now the question format, because this is where the ANCC creates its own unique preparation challenge. The ANCC includes multiple response questions, questions where you must select all correct answers from a list, not just one. There is no partial credit. You must get all correct answers to get the question right. These questions require a deeper mechanism-based understanding because you need to know not just the primary right answer, but the full set of clinically appropriate responses. They test comprehensiveness of reasoning, not just accuracy on a single choice. The ANCC may also use clinical scenarios that are longer and more contextually rich than typical AANP stems, giving you more information to synthesize before arriving at the answer. The ability to hold a complex clinical picture, identify the most clinically important element, and select the action most consistent with evidence and professional standards. That is what the ANCC is measuring. Side by side, what this means for your study strategy. Let me put this in practical terms now. You have both blueprints. You understand how each board approaches the clinical content. Here is how that translates into a study strategy for each. For the AANP, your study strategy should be weighted toward mechanism-based clinical reasoning in the assess and diagnose domains. That means, for every clinical condition you review, you should be able to answer 4 questions. What are the assessment findings that distinguish this condition from the closest differential? What diagnostic test do you order first and why? What mechanism does that test measure? What does a positive result tell you, and what does a negative result rule out? And what is the management approach and the mechanism that makes it appropriate for this specific patient? If you can answer those 4 questions for every high-yield condition in the blueprint, you are prepared for the AANP. Because the AANP is testing whether you can synthesize clinical data toward a correct clinical decision. And every question on the exam is constructed around that cognitive process. For the AANP, also prioritize pediatric content explicitly. Build a dedicated study plan for common pediatric presentations, otitis media, asthma, ADHD, developmental milestones, vaccine schedule and contraindications, pediatric vital sign interpretation, growth chart interpretation. These represent 22% of your exam. They will not let you pass if you ignore them. For the ANCC, your study strategy needs everything the AANP requires, plus a deliberate study block for the professional role content within implementation. This is not secondary preparation. It is 29% of your exam. And unlike clinical content where you may have clinical experience to draw on, professional role content, ethics, regulatory, research literacy may feel unfamiliar if your NP program did not emphasize it. Specifically for ANCC professional role preparation, know the 4 ethical principles and be able to apply them to clinical scenarios, not just define them. Know the levels of evidence and what they mean for guideline strength. Know what a PRN scope of practice looks like in full practice authority states versus restricted states, and what the implications are for your clinical decisions. Know the informed consent elements, what a patient must understand, what capacity assessment requires, and what to do when capacity is in question. Know your mandatory reporting obligations, which conditions, which populations, and what the legal threshold for reporting is. And for the ANCC, practice with multiple response format questions. The cognitive process for selecting all correct answers is different from selecting one correct answer. You need to evaluate each option independently against the clinical scenario, not compare options against each other. If an option is clinically appropriate and consistent with evidence, it belongs in your selection, regardless of whether you think another option is more appropriate. That comparative thinking will cost you points on multiple response questions. Which board should you choose? The honest answer is that both boards certify the same entry-level NP competency. Patients do not know or care whether you are FNPC or FNPBC. The clinical practice you are qualified for is the same. The prescriptive authority you carry is governed by your state, not your certification body. The decision should be driven by 2 things: your employer's requirements and your career goals. If your future employer or clinical site specifically requires one credential over the other, choose that one. Some hospital systems, VA facilities, and academic medical centers have preferences. Check before you sit. If your career trajectory leans toward leadership, academic practice, or roles where the professional role content the ANCC emphasizes is specifically relevant, the ANCC may be the more aligned credential. If your career is patient care focused in outpatient primary care and you want to take an exam that is clinically weighted and clinically formatted, the AANP aligns with that. What I would caution you against is choosing based on which exam you think is easier, because with mechanism-based preparation, with genuine understanding of the clinical content rather than memorized facts, neither exam is particularly hard. The students who fail both boards are not failing because the exams are too difficult. They are failing because they prepared by memorizing without understanding. And memorization fails under board pressure exactly the way we talked about in episode 3. The mechanism-based approach we build in every episode of this podcast is the preparation for both boards. Every differential diagnosis framework, every pathophysiology breakdown, every clinical reasoning case, all of it is board preparation. Not because it is designed as a test prep resource, but because it builds the clinical reasoning foundation that both boards are designed to measure. Athena did not walk into battle without a strategy, and you should not walk into your boards without one either. Both the AANP and ANCC are testing entry-level NP competency, but they are measuring that competency through different lenses, the AANP through a clinical synthesis lens, and the ANCC through a clinical synthesis plus professional role lens. Understanding those lenses before you open your first practice question is what makes your preparation efficient rather than exhausting. Here is what I want you to walk away with. First, know your blueprint, not the 2022 version. The current one, the AANP 2024 blueprint, is still in effect. The ANCC updated their outline in September 2025. If your study resources predate those updates, supplement them. Second, weight your study time to the domain weights. For AANP, that means assess gets the most time. For ANCC, that means implementation gets the most time. Third, the mechanism-based reasoning this podcast builds is your single most powerful board preparation tool. Because every board question on both exams is ultimately asking, given this clinical situation, what does a reasoning provider do? And that question has an answer when you understand the mechanism. For this week's homework, pull up the official blueprint for whichever board you are sitting for. If you have not looked at it recently, look at it today. Specifically, look at the domain weights and count how many questions each domain represents. Then audit your current study plan against those weights. Are you spending 32% of your study time on the assessed domain if you are taking the AANP? Are you spending 29% on implementation if you are taking the ANCC? If your study time distribution does not match the exam's domain distribution, you have a mismatch to fix before you go any further. Clinical reasoning tools, ebooks, and our Facebook community are in the show notes. The Think Like a Provider Academy waitlist is there too. When the Academy opens, board prep is a core part of what lives inside it. Strategy first, content second. Your certification is waiting, and I will see you next week.